Hello, in this final video on adrenal gland anatomy and physiology, I'm going to look here at cortisol in more depth and the actions of cortisol, look at DHEA and its actions, aldosterone and its actions, and then say a little bit about glucocorticoid therapy. So what does cortisol do? It primarily prepares the body to handle stress. And again, we have to look at cortisol effects really whether or not they're acute or chronic, because we get different effects. Acutely, we have what we might call the good effects of cortisol. They're going to prepare us for stress. Chronically, we start to see a lot of the negative aspects of cortisol come through. So basically fasting, stressors like fasting, fright, temperature extremes, high altitude, bleeding, infection, surgery, trauma, chronic disease, etc., all are going to cause increased CRH, ACTH, and then cortisol release. The following I'm going to describe here are more the acute and the short-term effects of cortisol. The long-term effects can often have the opposite effect, so it gets a little bit more complicated when talking about cortisol. Beyond cortisol, we're looking clinically much more at this ratio between cortisol and DHEA as more indicative of whether or not cortisol is going to have a negative or a positive effect in the body. The DHEA, remember, is primarily anabolic versus cortisol is more catabolic. So having higher DHEA usually is going to protect you from excess effects of cortisol and hypercortisolism. So one of the main effects, we call cortisol a glucocorticoid because it's going to increase plasma glucose levels. So it's going to increase hepatic gluconeogenesis. And remember, gluconeogenesis is making new sugar either through lactate, glycerol, which comes from fatty acid triglyceride breakdown, and or amino acids. And these are certain glucogenic amino acids, usually from muscle breakdown. So from fat breakdown, muscle protein breakdown, and lactate, which is the anaerobic product of a glucose breakdown in the cytoplasm via glycolysis, we can make new sugars. So cortisol stimulates all of those in the liver. Now, in the cortisol specifically is going to increase the hepatic glycogenesis. So it's going to actually make more glycogen in the liver, but it's going to actually decrease the muscle glycogenesis, so decrease the ability of muscle to make new sugar. It's going to increase proteolysis from muscle. It's going to increase lipolysis and release of fatty acids from adipose. And in chronic hypercortisolism, we are going to get increased lipogenesis. So this is where we get that interesting phenomena like in Cushing's syndrome, where we get less adipose in the peripheries, in the arms and the legs, and more adipose accumulating in the trunk. So it kind of liberates adipose but redistributes it. So with chronic hypercortisolism, we get increased lipogenesis in the trunk, truncal obesity. Also around the neck, the back, and the face. And then it's going to decrease peripheral glucose uptake in muscle and adipose, and that could lead to insulin resistance. So hypercortisolism states chronically are very similar to, and this would be Cushing's syndrome, are very similar to metabolic syndrome. Remember, metabolic syndrome really is insulin resistance, dysglycemia, with hypertension, with abdominal obesity, and with dyslipidemia, especially having low HDL, the good cholesterol, and high triglycerides. So that is where we're finding, we think, in metabolic syndrome, there's some problem with cortisol, probably locally. Again, overactivation of that local 11-beta HSD1, which is reactivating inactive cortisone into active cortisol. In glucocorticoid deficiency, we're going to see hypoglycemia, and that's going to be a very important syndrome for true adrenal fatigue. For Addison's disease is severe, potentially fatal hypoglycemia. And glucocorticoid excess, we're going to see hyperglycemia, hyperinsulinemia, muscle wasting, weight gain, abnormal fat distribution. Again, in the biomedical sense, this would be Addison's, and this would be Cushing's. Okay, So that's one thing on glucose levels. Another effect on cortisol is to increase blood volume and pressure. So cortisone, both cortisol but also cortisone act at the mineralocorticoid receptor in the kidneys, and that's going to increase the glomerular filtration rate in the kidneys, and it's going to also increase sodium and then water retention, and that will increase blood pressure. It's also going to increase the excretion of potassium, calcium, and phosphate via the kidneys and the GI tract. So you're going to lose all these electrolytes, but you're going to retain sodium. So high sodium, low potassium would be indicative of a high cortisol state, or low cortisol, we're going to see often low sodium, maybe high potassium. The other main effect is on inflammation. So we usually think of the cortisol, but also exogenous glucocorticoids as being anti-inflammatory. In the process, inflammation is a very important part of the healing response. So if you suppress inflammation, you're also going to suppress healing, specifically tissue repair, and that's because cortisol is going to inhibit fibroblasts and all of their activity they should be doing for tissue repair. So in general, cortisol decreases mast cells, and that will decrease histamine release. Now again, that's acutely. More chronically, with elevated CRH and ACTH, we're going to see more histamine receptors and more histamine activation. So that's a confusing one. So cortisol chronically can actually lead to hyperhistamine states, opposite of what you might think. And then you're going to decrease your antigen-presenting cell activity, decrease T cell activity, decrease IL-12, interferon gamma, interferon alpha, TNF alpha. These are all the cytokines used by the T cells and the APCs. And you're going to see an upregulation more of Th2 activity. So we get decreased Th1, which helps you fight bacteria, viruses, and we're going to see more Th2, which is allergies. And so we're going to shift everything towards Th2, especially with chronic hypercortisolism. Going to decrease capillary permeability, more leakiness of capillaries, more apparent signs of bruising, decrease phagocytosis, decrease natural killer cell activity, so less tumor and viral surveillance. And then over time, we might decrease thymic volume in T cell maturation. Decrease phospholipid A2, which again is the source of eicosanoids in your plasma membrane, so it's going to decrease that. And so upstream from where the COX inhibitors work. And it's going to increase copper enzyme activity, including superoxide dismutase. And this will help with actually superoxide production to act as a bactericidal agent. So in general, we can think of cortisol as tamping down the Th1 inflammatory response. Over time, it might shift you more into a Th2 response. The effect on white cells overall be a little more confusing. In general, we'd see the cortisol levels increasing neutrophils and platelets, and then decreasing specifically the T and B cells, the lymphocytes, and eosinophils and basophils. So it gets a little bit more complicated. And again, this can be confusing depending on if we're talking about acute versus chronic activation of cortisol. On the brain, cortisol works to increase alertness in the CSF, so it readily crosses the blood-brain barrier. In the short term, it creates what we call flashbulb memories, picture memories of different emotional events, and that usually goes along with elevated epinephrine secretion as well. So this is where we get, maybe a trauma. We're in an auto accident, and that picture, if we, for example, saw someone die in that accident or something like that, just remains with us. That's called a flashbulb memory. Unfortunately, long term, if this system remains overactivated, the HPA axis and cortisol, this will again damage the hippocampus and result in decreased memory, as well as excess states could cause damage to the amygdala and other areas. And so we might see things with more irritability, emotional lability, depression, mania, psychosis, different cognitive impairments, and then overall maybe a suppression of melatonin, things like insomnia, decreased REM sleep, and decreased libido with depression of your sex hormones, especially androgens. The decreased states, we might see the opposite effects in cortisol. So that is more apathy, lethargy, sort of chronic fatigue. So that's some of the effects of cortisol on the brain. Again, with wound healing, cortisol inhibits fibroblasts, leading to loss of collagen and connective tissue. We might see more thin skin, easy bruising, the purple striae formation, poor wound healing. That would be in cortisol excess states. In bone, we're going to see decreased bone formation, increased resorption, so bone loss. Cortisol might also potentiate the effects of parathyroid hormone to mobilize calcium from the bones, leading to more bone loss. It's going to decrease intestinal calcium absorption and increase renal clearance, and again, this would cause hypocalcemia. So hypocalcemia could be a product of excess cortisol production in the body. Growth and development. In the fetal development, very important, cortisol for stimulating fetal growth and development, like lung maturation, as I spoke about, increasing pulmonary surfactant. But if an excess in children and teens, this could inhibit growth and development. In general, cortisol increases cardiac output via increasing inotropy and chronotropy, and increases peripheral vascular tone because it potentiates vasoconstrictors like epi and norepi, which would lead to hypertension. And then at high levels, it acts as the mineralocorticoid receptor to also increase blood pressure. And then digestively, dysregulated cortisol really has been shown to play a role in nearly every chronic GI disorder, including peptic ulcer disease, gastritis, irritable bowel syndrome, and IBD. So I often am going to be looking at the HPA axis in all those GI disorders. And then it has different effects on other endocrine glands. A big one is thyroid. We often see cortisol excess as a thyroid suppressant, basically. So it's going to decrease TSH synthesis and responsiveness of the pituitary to TRH from the hypothalamus. Decrease the total T4, but the free T4 usually stays normal. And it inhibits the conversion of T4 to T3. Specifically, it's going to make more reverse T3, which is pretty much inactive and won't work at the thyroid receptor. So you can think of cortisol in general as inhibiting thyroid activity. In the gonads, it's going to suppress gonadotropins, and that would lead to suppression of the sex hormones with all those downstream effects. So these are some of the more general actions of cortisol that we typically don't talk about as much in the conventional endocrine sense, but definitely for functional hyper or hypercortisolism, we definitely see more of these effects coming into play clinically. So I've mentioned several times that DHEA really provides a counterbalance to cortisol in the body. This is an adrenal androgen. And both DHEA and specifically DHEAS are the most abundant circulating steroids in the body, both in males and females. The DHEA is synthesized primarily from pregnenolone in the adrenals, although other tissues like the gonads and even the brain can synthesize its own DHEA. And I'll talk about that here in just a minute. Only the adrenals, the brain, the lungs, liver, kidneys, intestines can sulfate DHEA via DHEA sulfotransferase, but nearly all tissues can desulfate the DHEAS into DHEA via sulfatase. So think of DHEAS as more of a pool put out largely by the adrenals into the plasma, and then other tissues can remove that sulfate and use the DHEA locally. Salivary DHEA we think is the best measure of DHEA levels, much better than the plasma tests. It correlates very well with the free plasma DHEA levels, but we usually measure it in conjunction with cortisol, and this gives us the cortisol DHEAS index. So that's important. Now salivary DHEA is going to parallel DHEAS, but it's not the same thing. So in the saliva we're going to measure DHEA directly, versus in plasma, we usually measure the DHEAS. DHEAS, again, is the primary storage form, comprises about 98% of circulating DHEA, so the levels are a lot higher than DHEA, but they're proportionate. The plasma DHEA levels are about 10,000 times higher than plasma estradiol in females, so much more abundant in females. In fact, in females, DHEA and DHEAS are the primary androgens, much more abundant than testosterone, and it's going to provide a pool to make estrogens and so forth. DHEA is the DHEAS can travel by itself. It can also bind to albumin, which delays its clearance and prolongs its half-life. So there's no real plasma circadian rhythm with the sulfated form. And the levels run parallel with DHEA, and they correlate with clinical signs and symptoms of androgen deficiency and excess. So excess DHEA, you're going to get all the hyperandrogen symptoms. Like in females, you might see hirsutism, acne, all those sorts of things. Can also suppress normal ovulation and menstrual function. In males, looking at DHEA excess is more difficult because it's usually sort of goes along with testosterone, so it's harder to differentiate those. Many researchers argue that the DHEAS is actually a better measure of overall adrenal cortical activity over time. So it's a measure of what we call the biological reserve of the adrenals. It does not, though, the DHEAS does not cross the blood-brain barrier, so it's going to stay in the plasma. DHEA, again, you remove the sulfate group, it's more active, it can be converted into the sex hormones, it has a circadian rhythm like cortisol, short half-life, about 30 minutes, and it's a better measure of the effects of acute stressors, but not chronic adrenal reserve. So both DHEA and DHEAS have their roles in terms of looking at both acute and chronic adrenal reserve. The tissue levels, again, of specific DHEA sulfotransferases and the steroid sulfatases are going to determine the balance between DHEA and DHEAS and DHEA in different tissues. The levels of DHEA are inversely correlated with plasma LDL. So that's an interesting one. As DHEA levels go up, your LDL should go down, and vice versa. So I often look at that with my chronic cardiovascular patients with high LDL, looking at potentially low DHEA as a contributing factor to why they're having high LDL. About 60-70% of DHEAS is produced each day is converted to the DHEA. So the majority of it is going to be via the steroid sulfatase. The sulfate group is removed to make DHEA. And only about 13, a little bit more, percent of DHEA is metabolized to DHEAS. All right, so this is the major steroid synthesized again by the adrenals of the fetus before birth. The plasma levels are detectable by age 7. Again, that's the start of adrenarchy. And we're going to see that rise between ages of 8 and 11 to a maximum of around age 25. And then the levels will decline about 2% each year. And so at age 70, we only have about 15 to 20% of the maximal peaks, and that is when we reach andropause. The problem is that although DHEAS declines, the cortisol levels are going to remain constant. So that's going to increase the ratio of cortisol to DHEAS, and that has definitive negative effects on the hippocampus and different brain areas and so forth. So people, you can say, become less resilient to stress with an increased cortisol to DHEAS ratio. Now, the functions of DHEA, both forms, DHEAS and the direct form, have direct actions on tissues, but mostly only DHEA has been studied, so we're going to focus on that one. Really is a wide range of activities. It regulates fat catabolism, energy levels, memory, immune function, and so forth. And then both these act as neurosteroids. A neurosteroid is a hormone that acts on the brain. In fact, we're beginning to find that all the sex hormones and the adrenal steroids are major contributors to central nervous system function. So there's an interesting notion in Chinese and traditional medicines that the brain is an excretion of the kidneys. And if we think of the adrenals and the gonads as part of the kidney system, that's true. We know that those steroids all have major effects on neurotransmitter balance, development of neurons, of glial cells, and so forth. Really, DHEA works in two primary ways. It serves as a substrate, first of all, for androgen and estrogen synthesis. So going back to the steroidogenesis pathways, remember DHEA was kind of the precursor to the androgens, and then via aromatase, the estrogens. But we also know that DHEA has direct tissue actions through various receptors, although again, there's been no specific receptor for DHEA discovered yet. So looking at that first aspect, the substrate for sex hormones, DHEAS can be taken up into various tissues, the sulfate group removed, and then it's rapidly converted into androstenedione. This is an androgen via 3-beta hydroxysteroid dehydrogenase. And then androstenedione can further be metabolized into testosterone or dihydrotestosterone, DHT. And that's via the enzyme 5-alpha reductase that converts those two. And then androstenedione can be aromatized to estrone, E1, and it can also be aromatized to estradiol. So here's androstenedione over here, here's DHEA, and here's aromatase to make estrone. We can also convert androstenedione to testosterone, and then aromatase can make that into estradiol. And those act at the estrogen receptor, the androgen at the androgen receptor, and here's the dihydrotestosterone works more strongly at the androgen receptor, and so forth. So this is where DHEA kind of is sort of the mother hormone for all of these androgens and then estrogens. Now, one of the problems of giving DHEA as a supplement is that in males, for example, as they get older, their DHEA levels go down, but their aromatase levels in the tissues go up. Meaning that if you give DHEA, it converts into androstenedione, maybe testosterone, and then it's all aromatized into estrone, maybe estradiol, which is what you don't want in an elderly man. We know that in males, high estrogen will lead to increased abdominal obesity, as well as worse cardiovascular outcomes. So there's a problem of giving the DHEA supplements because of that. So off-label, there are people that use DHEA, like for example, bodybuilders, they might use it, but they'll take an aromatase inhibitor like chrysin, which is a flavonoid that we have in passion flower and other herbs, to inhibit that aromatization into estrogen. Or there's a form called 7-keto-DHEA, which is not aromatized, not metabolized, especially to the estrogens. Probably does have action on the androgens, but we think of it more as keeping the DHEA activity and working at the DHEA receptors, which I'll talk about here in just a second. So if you look at the DHEA and DHEAS, they serve as precursors for up to 30 to 50% of total androgens in men, 75% of estrogens in premenopausal women, and 100% of active estrogens after menopause. So that is essentially where the adrenals take over the effects of the ovaries after menopause. So with herbal therapies, I'm working a lot with adrenals postmenopausally. In fact, for hot flashes and all those things, phytoestrogens are sometimes like black cohosh and whatnot. We discuss those. But more importantly, I find is actually working with the adrenal hormones, with the adaptogens. So that would be, I'll talk about that with the male and the female reproductive sections. The dose-dependent effects will vary. So 100 milligrams of DHEA a day will increase androgens in postmenopausal females and increase estrogens in older men. This is a very high dose. We're looking at clinically maybe between 5 and 10 milligrams if we're going to supplement DHEA, and I'll talk about that here in a bit. I personally find actually that the adaptogens, those stimulant adaptogens like the panax, rhodiola, codonopsis, schizandra, licorice, those are much better at raising DHEA than actually taking DHEA supplements. We want to really get the glands to secrete the hormone on their own, not provide it artificially, because whenever you provide a hormone exogenously, there's always the risk of down-regulating endogenous secretion. We don't want that to happen. So I try to do everything first to get the glands secreting on their own by providing the right nutrition and maybe using herbal therapies. But, up to 100 milligrams a day, we do see the androgens going up in females and estrogens in older men. So that's probably too much. Again, in females, we're usually using between 5 and 10 milligrams a day of DHEA if we're supplementing it, and males usually not going above 20 milligrams a day. All right, so that is one aspect of DHEA, is a substrate for the sex hormones. The other is to work directly on receptors. And there are different receptors we think that carry the actions of DHEA. So no specific DHEA receptor has been found, but peroxisome proliferators, PPAR alphas, pregnane X receptors, what's called the constitutive androstanol receptor, CAR, estrogen receptor beta, which we'll talk about as sort of a good estrogen receptor that gives us the positive effects of estrogen. There are potentially membrane-associated DHEA receptors, and in the brain, it acts as a sort of pool, as this neurosteroid and a modulator for different neurotrophic growth factors. So these are more indirect effects of DHEA, again, probably not mediated through a specific DHEA receptor. All right, so that's a lot on DHEA. I just want to emphasize that because it is such a key hormone. One final little tidbit again from Chinese medicine, there's this notion of what they call the kidney qi. And this is sort of the basic basal energy that maintains all your physiologic systems, digestion, cardiovascular, respiratory, and so forth. If we were to look for a molecular or a substance correlate to kidney qi, we can make a very strong argument that DHEA is that correlate. So that's why I do look at this very seriously in the clinic and use it a lot in my treatment plans. So let me just summarize some of the actions here of DHEA. In males with normal gonadal function, the conversion of the DHEA into androstenedione and testosterone accounts for less than 30% of total testosterone production. So we don't really think of DHEA from the testosterone perspective in males, but we do see it a lot playing out with maybe decreased resistance to stress and so forth. Just like we talked about with adrenopause, there is an andropause where in males the level of testosterone from the testes goes down significantly with age. It sort of parallels adrenopause, but usually andropause happens a little bit more quickly. So the adrenals should kick in to help a little bit with that androgen synthesis. And again, when I'm working with older men with maybe low testosterone, one of my treatments might be to use herbal, what we call phytoandrogens. These are herbs to try to increase testosterone activity in the body, but also those stimulant adaptogens to increase the DHEA activity. We're going to see more androgen excess problems from, let's say, oversecretion of DHEA from the adrenals in boys, where we might see premature puberty, early development of sexual characteristics, early penile enlargement, that sort of thing. Usually physiologic replacements in oral doses are thought about in terms of age. A lot of the guidelines sort of suggest after the age of 40, between 20 and 50 milligrams a day. Again, if I'm going to replace DHEA, I'm usually a lot more conservative, maybe 10 to 20 milligrams a day. Would be where I would start. But I'm going to really try to use the herbal therapy and nutrition first before going down that road. In females, DHEA is probably the primary androgen, and then via peripheral conversion into androstenedione and testosterone, this contributes the major source of female androgens. The premenopausally, most DHEA is released during the follicular phase of the menstrual cycle. So it contributes to androgen production then. And then if we have excess androgen secretion, we see that, for example, in Pcos, we have acne, hirsutism, or other signs of virilization. The adrenals then, after menopause, become the major source of estrogen and progesterone post-menopause or post-oophorectomy, where the ovaries are removed surgically. If we look at the plasma levels, they can be useful to detect excess or deficient adrenal gland activity. And especially in women with PCOS, about 30% of them have elevated DHEA from the adrenals. We see also exercise and even caloric restriction will also increase DHEA levels. So that could be helpful to measure there. The recommended physiologic dosage in females by age after 40 is between 10 and 30 milligrams a day. Again, I'm usually, if I'm going to be doing it, giving between 5 and 15 milligrams a day, much lower as a starting dose. But I'm also doing a lot of the other therapies with that, the herbal therapies and nutrition. A lot of interest in looking at DHEA having anti-aging effects, but nothing that's really been recommended for clinical application at this point. But there are people using DHEA supplements for that reason. Again, I would argue that herbs and nutrition are probably a better place to start. In the brain, both DHEA and DHEAS are neuroactive steroids, as mentioned. They increase neurogenesis, neuronal growth, differentiation, neural protection, reduce neural inflammation, and glutamate excitotoxicity, and they potentiate dopamine signaling. So we can think of DHEA, DHES as really supporting dopamine and all the effects downstream that dopamine gives. Both GABA agonists has both GABA agonist and antagonist effects. So on GABA signaling, it has variable effects, can kind of upregulate GABA in some instances and also downregulate in others. Reduces myelin loss and reactive gliosis in multiple sclerosis, and it's potentially protective in Alzheimer's, Parkinson's, dementia, ALS, and adult onset schizophrenia. So a lot of very protective roles of DHEA in the brain. In the regarding mood, DHEAS levels are positively correlated with better memory, attention, and concentration. And DHEAS levels are inversely correlated with hyperactivity. So a low DHEAS, we might see more anorexia, depression, and fatigue. High DHEA, more mania, irritability, PTSD. Something to keep in mind. This is a very important topic to look at the connection of mental health and mental health disorders with the endocrine system. Huge associations with that, and that's something we can directly target in our clinical work. Let me just quickly go through the last set of actions here of DHEA. There's a lot of them, just going through the different organs. So in the case of the heart and the cardiovascular system, we think DHEA is endothelial protective. Now that's been studied primarily at supraphysiologic doses, but we can argue at the physiologic doses there's probably some degree of endothelial and cardioprotection. We do know that low DHES is positively correlated with high LDL, as I mentioned, and atherosclerosis. There are also antihypertensive effects at the physiologic levels, but if you start getting too much, we get elevated androgens, and that could increase blood pressure. Diabetes. In animal studies, DHEA supplementation has shown improved insulin sensitivity and decreases diabetes and obesity, especially abdominal weight gain. Human studies have been mixed. Again, with PCOS, we have two different types, ovarian and adrenal PCOS. And it's the ovarian that's related more to increased testosterone and insulin resistance, usually with more body weight, obesity. But the adrenal PCOS is more related to stress and increased DHEA, overactivation of the HPA axis. So herbally, I find they need different treatments. If we're working more functionally, ovarian PCOS responds better to insulin sensitizing agents like the bitter melon, gymnema, herbs or nutrients like chromium, but also things like inositol. All is helpful for that. But the adrenal would do better with working with the sedative adaptogens like ashwagandha, bacopa, holy basil, phosphatidylserine, manganese, lithium, etc. So that's the adrenal PCOS. In the lungs, again, DHEA has, along with cortisol, has a very protective role. We know that in idiopathic pulmonary fibrosis, DHEA has an antifibrotic effect, and pulmonary hypertension is improved with DHEA. In asthma and allergies, very important consideration. A lot of my, especially pediatric asthma patients, respond very well to the stimulant adaptogens, which upregulate the DHEA, and this helps to decrease their use of inhalers and makes their need for inhaled corticosteroids a lot less. In the GI tract, IBS is associated with decreased DHEA levels and high cortisol DHEA ratio. And then in IBD, we see that DHEA decreases intestinal inflammation. It's a very important one there. In the kidney, DHEA supplementation has potentially harmful effects, although that's probably based on using supraphysiologic doses. We do know that low DHEA in hemodialysis patients is associated with increased mortality. Again, if that's a cause or just a correlation is unknown, but that's an interesting one. Metabolically, I mentioned the anti-obesity effects, which are mixed in clinical trials, but in general, DHEA will decrease total cholesterol and LDL in younger males. And low DHEA is often correlated with hypothyroidism. This one's very important. A lot of people come in with what we've talked about before as subclinical hypothyroidism. And in reality, it's because of low DHEA. And so I usually correct that first before I start giving any thyroid replacement or any sort of thyroid support. So that's something to consider with your patients. In immune system, DHEA works opposite to cortisol. Remember, cortisol turns down, especially the Th1 responses, upregulates Th2. DHEA upregulates Th1. So it really increases the T cell and the natural killer cell activity. And this can be mixed. Of course, we have to be careful in autoimmune disease like lupus. We don't really want to turn up that Th1 too much. But in lupus, it's interesting, there's a cytokine IL-2 from T cells, which is decreased in lupus, and DHEA restores this. So DHEA is a little bit more complicated in the case of autoimmunity. In fact, a lot of patients with autoimmune diseases are on high doses or fairly high doses, maintenance doses of cortical steroids like prednisone and so forth, and that will naturally suppress DHEA. So giving DHEA supplements along with that can sometimes be helpful to get more of the protective effects going there. And in some of the studies with lupus in particular, DHEA at 200 milligrams a day for 3 months improved outcomes of lupus. Potentially suppresses HIV replication. I think that was more of an animal study. In bone, DHEA 50 milligrams a day orally for 12 months increased bone density, decreased other markers of bone turnover in women over 70. So it may inhibit bone resorption and increase bone formation. Okay, so that's a lot on DHEA, but I just wanted to really give that as an example of how important this hormone is, especially as a counter hormone to the potentially negative effects of cortisol. One final area would be using DHEA as treatment. There's really unclear guidelines regarding this. What's the best form, the 7-keto or the regular DHEA? Who's it most useful for? It is important if you're going to think about supplementing to always consider hormone testing. We usually think of salivary testing most accurate for the DHEA levels before you give DHEA supplements. And you want to really follow the therapeutic order in this. DHEA, though, is considered relatively safe. I had studies looking at giving 1,600 milligrams a day to healthy volunteers for 28 days. And that did result, however, in mild insulin resistance, but no other significant effects. In the lupus studies, I mentioned using 200 milligrams a day for several months. That was well tolerated, except for some signs of increased acne and hirsutism. Thyroid toxicosis has been observed in some patients on thyroid medication taking DHEA, and that's because DHEA potentiates thyroid hormone. I've seen that a fair amount where I have patients coming in with previously diagnosed hypothyroidism. They might not have particularly elevated antibodies to thyroid, so it's unclear if they have Hashimoto's. And we maybe start supporting the adrenals and the DHEA, and now they start getting hyperthyroid symptoms. So we need to lower their thyroid medication. I've had a couple of patients who were able to completely get them off thyroid medication just by supporting the DHEA. So really consider that with your hypothyroid patients. So with the therapeutic order, really our level 1 is going to be our best, looking at healthy diet, exercise, sleep hygiene, and stress reduction. That's very important. Looking at level 2 therapies, here we want to maybe think about stimulant adaptogens. Again, the Panax ginseng, but also Oplopanix in that same family, Aralia, Cotinopsis, Eleutherococcus. All of these would be considerations there. Rhodiola, and then licorice and Schizandra. I would think about as more stimulating adaptogens to increase the HPA axis in DHEA. And then phytoandrogens really support testosterone production, so I'll talk about those later in the male reproductive section. Vitamin C, B5, B6 are all cofactors for adrenal steroidogenesis, as are copper and magnesium. And then adrenal glandulars or protomorphogens we can think about as giving the right nutrition to the adrenals to maybe help them function better. So I'm usually starting with level 1 and level 2 first. If we do use DHEA, we can use it topically for skin ailments. This is just going to have the topical is going to stay locally. Oral DHEA is going to cause a rapid rise in DHEA sulfate in the plasma. And the DHEAS won't cross the blood-brain barrier specifically, so it's going to be more having effects on the GI tract, the lungs, the kidney, and so forth. Typical doses, males 10 to 30 milligrams a day, females 5 to 15 milligrams a day. We consider 50 to 100 milligrams a day probably are super physiologic, but we might need those doses in autoimmune disease depending on if you're trying to use more of a suppressive therapy in that case. 7-keto DHEA, little information on this, but it doesn't convert to the estrogens, so we think of that being potentially beneficial. And then there is a sublingual form of DHEA. It's not sulfated. This acts directly in the brain, but that's been shown to actually increase agitation in some people. But for real chronic fatigue, low motivation, low mood, all that sort of thing, with maybe evidence of low DHEA in the body, that might be something to consider. All right, so that's DHEA treatment. Our last hormone here is aldosterone, produced by the outer rim of the adrenal cortex, the zona glomerulosa. And you probably studied this already in cardiology, but this hormone is really important for regulating blood pressure and plasma sodium levels. So it's going to be part of the renin-angiotensin-aldosterone system. It's going to act at mineralocorticoid receptors, primarily in the distal tubules and collecting ducts of the kidneys. And that's going to essentially increase sodium retention in the kidneys, and that will increase water retention, and that'll drive up blood pressure. Has the exact opposite effects to atrial natriuretic hormone. This is from the heart, a cardiac hormone. So as the atrial chambers are stretched with increased fluid volume, you'll get more of this hormone being secreted, and that actually tells the kidneys to diurese. So think of ANF and aldosterone as being opposite in their actions. There is a diurnal circadian rhythm to aldosterone secretion, but basically the primary stimulus for release is increased angiotensin II. ACTH has a little bit of an effect, has a minor role. It promotes the synthesis of aldosterone, but not the release. Increased plasma potassium levels is a very potent stimulator, and then increased acidosis. So think of aldosterone is kind of working with antidiuretic hormone to increase your fluid body, your fluid volume, and that could be helpful acutely if you're hemorrhaging or have something like that going on. You're trying to dilute out a toxin in the blood, etc. But of course, chronically, this could be overactivated and create chronic hypertension. So the three main effects, again, are to increase sodium reabsorption, and this happens in the principal cells of the collecting ducts, promotes the sodium reabsorption and reduces excretion, increases arterial pressure by that sodium reabsorption, and the net effect is to essentially increase the extracellular volume and then increasing potassium excretion. So in aldosterone secreting tumors, we're going to see very high sodium, low potassium, and increased blood pressure, and that could be an important cause of secondary hypertension. I'll say a little bit about that in the adrenal pathology section. Finally, I just want to include a little note here on cortical steroid therapy. So there are several semi-synthetic derivatives of glucocorticoids that have been developed for their anti-inflammatory action. Some of them have mineralocorticoid effects as well, and that can increase sodium and blood pressure. And they have various durations of action and various delivery methods. So we can do it orally. There are injectable forms, intravenous. There's topical forms. There are forms that can be taken as an enema, intranasal, etc. So hydrocortisone, this is again same as cortisol. We define that as having a glucocorticoid potency of 1 and a mineralocorticoid potency of 1. Has a duration of action of 8 hours. Cortisone, again, less active as a glucocorticoid and mineralocorticoid. But in some tissues like the skin, it can be activated back into cortisol. Prednisone has up to 5 times the activity of hydrocortisone, but a little bit weaker as a mineralocorticoid, which is good, but up to 3-day half-life. Prednisolone, that's about 4 times the potency of cortisol, again, weak mineralocorticoid, again, fairly long half-life. Methylprednisolone up to 7.5, even less mineralocorticoid activity, up to 40 hours half-life. Dexamethasone, this one is a big hitter. And we'll see this is actually a test that we can do for adrenal function, the so-called dexamethasone suppression test. So you take oral dexamethasone, high dose, that should suppress your pituitary from secreting ACTH. But if you have a pituitary adenoma hypersecreting ACTH, the dexamethasone won't suppress it. So that's called the dexamethasone suppression test. This one has up to 80 times the potency of cortisol. No mineralocorticoid activity, which is good. And then up to 50 hours half-life. Betamethasone, another one there. Triamcinolone, that has a you often use on the skin. And then beclomethasone, this is done as an oral inhaler for asthma. And then fluticortisone, this is our primary mineralocorticoid replacement. So when we talk about Addison's disease, we're going to need to supplement potentially in primary Addison's mineralocorticoids, and fluticortisone has a mineralocorticoid potency of about 200 and about a 24-hour half-life. So that sometimes needs to be taken with cortisol in Addison's primary adrenal insufficiency. And then aldosterone here, we just define having a mineralocorticoid potency of 200 to 1,000. Okay, so the main effects of the glucocorticoids here would be anti-inflammatory through all the different mechanisms we've already talked about, decreasing the prostaglandin and leukotriene synthesis by inhibiting phospholipase A2, redistributing leukocytes throughout different body compartments, decreasing the lymphocytes, stabilizing mast cells, and decreasing activation of the kinin system. Unfortunately, we have a lot of adverse effects too, and this is a very important point. I'll just highlight this here in red. So any doses of prednisone or any of these other steroids greater than 5 milligrams a day and used for more than 2 weeks can suppress the HPA axis. So if you discontinue them, you have to taper. So very short, 2-3 day pulses of up to 80 milligrams like a prednisone, we usually don't need to taper that. But if you're using it for more than a few days, we always think about tapering, because this could lead to secondary adrenal insufficiency. You've suppressed your pituitary, no more ACTH, and the adrenals don't get the right signaling. And that could, in some patients, be lethal. But more chronically, what we see with chronic use of these is more Cushing's-like effects. And that would be things like osteoporosis, decreased growth in children, hypertension, glaucoma, increased risk of infections because of poor wound healing and immune responses, maybe more agitation, euphoria, but potentially depression long-term, peripheral edema, central distribution of body fat, so truncal obesity, hirsutism, peptic ulcers, and hypokalemia. So these are all things that we have to be on the lookout for. Again, DHEA may have a mitigating effect on that. So for chronic for patients using glucocorticoids like prednisone chronically, I often think about, in those cases, actually supplementing DHEA to try to protect a person from all those glucocorticoid effects. All right, so that wraps it up for the anatomy and physiology of the adrenal glands. A lot of information, but that'll set the foundation for us to look in more detail at adrenal disorders.